2 to 5%. It affects 2 to 5% of deliveries. That will be worse in higher risk pregnancies and deliveries. It starts becoming a problem after 1,000 mil, only if you're talking about very healthy women. You're not talking about women who are anemic or obese or have any other medical conditions. So any patient of yours who is losing any amount, even 500 mil only, but she's at a higher risk, you have to treat her immediately as a postpartum hemorrhage. You increased in any patient over 500 or a higher risk patient, you increase supervision and initiate interventions. And any other patient, and that is specifically correct if the patient is showing any symptoms such as lower blood pressure or dizziness, pallor, any of the rest. Do I have any feedback? Is everything going okay? I will assume that everybody is listening. Okay. We always start with prevention, and you prevent it by knowing who are at risk. And these are a list of patients who are at risk. That there's no point reading. You tailor your management of the labor according to how high risk your patients are. The mainstay of prevention is active management of third stage of labor. Amticel, or it's basically active management of third stage of labor. We have to be very specific about that, and that بالمناسبة, one of the main things that will come in the exam. You will be definitely asked about that. And what is active management of labor? Active management of labor has changed slightly in the last few years. However, the one thing that you always start with is oxytocin. Oxytocin, you need a urotonic, and it is basically 10 units IM. It's not going to affect your hypertensive patients, unlike other mixtures. And controlled cord traction. It's very important that the juniors are taught very clearly what is controlled cord traction. They should not do it wrongly, because that would end in severe complications of uterine inversion. So continuous controlled cord traction is a mainstay of active management of labor. We add to it now trans-abdominal uterine massage, which is what the midwives do anyhow. If you just are in the maternity Omdurman or any of the maternities in Sudan, the midwives are amazing at trans-abdominal uterine massage. So that now became the third part of active management of labor. So please, these three things, you have to repeat them in your exam clearly for the also. Cord traction, that's what cord traction is. The main thing about it is that you have to put your hand abdominally and prevent inversion of the uterus. Management of postpartum hemorrhage is that you also have to clearly know for your exam and for your life and for everything in obstetrics that they're the four main causes. The main one, 70%, is tone. So that's why always we start by using uterotonics. And trauma, second thing. So of course we'd go with we're also supposed to reduce the number, to reduce bleeding, we reduce the number of episiotomies. However, this luxury is not exactly available to many of your patients in Sudan, who you'll need to do an episiotomy, at least an anterior one. A posterior one, try to reduce them if you can. And other traumas need to be treated, obviously. Tissue, retained placenta is about 10%. Thrombin is a rarity, but we should always keep it at the back of our mind. So initial management, in all your exams, anything to do with life support, or obstetric life support, any sort of life support, physician, pediatrics, all life support, you have to ask for help first. And once you realize that there is bleeding, and that has to be done very clearly by really assessing the bleeding, always be hyper aware of any patient you're delivering, to look for any signs of bleeding. The amount of blood, it shouldn't be underneath her without being detected. So Once we asked for help, we immediately start bimanual uterine massage. So if you think you need to manage this bleeding, she's bleeding over 500 mil, or she is over 1,000, or it's between 500 and 1,000, whether she's high or low risk. And then you need to do bimanual massage, not just the abdominal massage that we're talking about. That's part of active management of labor. That was prevention. Here we're talking about treatment. So you come, catch the woman, you do abdominal, you hold her from both sides, both hands. You ask somebody to fit in an oxygen, and you have to know it has to be 100%, has to be 10 liters, has to be on a non-rebreather face mask. So not any other type of mask. And it has to be 100%, 10 liters. So high, high, high. Obviously, you need an airway to get that in, and large bore IV. So green needles and the small ones are loss of time. Don't even go there. You need large bore. Don't trouble yourself fitting anything else. Blood products, that is standard. This is how you do the bimanual. Most of you would know it. The juniors maybe need to try it. They need to realize the difference between the actual physical feeling of just abdominal massage and bimanual compression. Now we come to the oxytocics. For the sake of the exam, you need to know these doses, you need to know the amount, you need to determine how to administer them. Please, that's for the exam, you need to know it. The rest of it just makes sense. You monitor the blood pressure, you monitor the heart rate, you empty the bladder. You are emptying the bladder for two reasons. You want to make sure she's not going into shock, and you need to measure how much is her output. So empty it first and then put her on a catheter, so that any very ill patient has to be on a catheterization and somebody checking it every hour and writing it down. That's if you're doing proper management. And the other thing is that oxytocin, you're putting it in with a lot of fluid. So you don't want this patient to get any respiratory problems out of overloading. So these are the two parts that necessitate checking the urine output. Now, common uses, we said we did the transabdominal uterine, the bimanual massage, as well as we started oxytocic agents. Whether you use oxytocin, prostaglandin, methylgonadrol, any type, all the types that are in the book, you need to memorize them and be able to give them to the examiner in the also. على بلاطة كده تحفظون صم وتخشوا الامتحان. Misoprostol, all the rest. Each of them is going to have advantages. The main thing you have to know is the contraindications and the adverse effects. So they say to you, a patient, you gave her prostaglandin and she started vomiting. Yes, it's a known side effect, so it's nothing new. So we go to the next reason, trauma. Lacerations, hematomas, you have to be able, you need to be a bit experienced to realize a hematoma. If a patient is that ill that you reach the stage, you finish the uterotonics and you're coming, you couldn't find the uterus well contracted, she's still bleeding, she needs assessment for trauma, by then your senior specialist or your consultant should be there. This is no joke, because such a person would realize also when uterine rupture happened, uterine inversion should have been prevented even by the junior, but in case it happened by any disaster, he needs to manage it, or she needs to manage it. So these are just examples. Uterine inversion, we said that is an emergency, because the longer you wait on it, it becomes almost impossible to revert. So the minute it happens, it needs to be immediately returned, so that you don't need, if you're a bit later, just a few minutes later, you might require anesthesia or nitroglycerin or any of the rest. And these women, they collapse, they get a vagal reflex. They tend to, even fitting an IUD through the cervix, you can get vasovagal attack. So be aware of that very much. Once the uterus is returned into place, you need to use uterotonic at a very high doses. High normal, high within the acceptable, but still high. So this is a uterus that went out, immediately push. You can't push it all the way. You have to push it slowly, slowly. So this is the first stage. And this is the second stage. Once you are inside, you keep your hand inside until the uterotonics work, and because you are not using them before, until you've returned the uterus. Tissue. Now that's the third reason. And then when you found that the uterus well contracted, there is no trauma, and the patient is bleeding, then you think, is there any stuff left inside? And that does not mean getting an ultrasound machine next to you and finding 5 millimeters of tissue and saying that this is a patient who needs that. It is normal after a normal delivery is that there should be some products. Don't go immediately interfering surgically and perforating this woman. The uterus is extremely soft and friable at that stage. So you first go old-fashioned. Old-fashioned is best. Take the placenta, look through it, get a midwife with you to look through it to make sure that there's no missing lobes. If there's a big fat lobe sitting in there, you need to remove it. There's no 2-3 about it. And more important than that, I believe that all women should be delivered in a place with a blood bank. But then that's me. I hope that many share my thought. So, and definitely if a patient has placental invasion, not only a blood bank, but I'll make sure there's a lot of blood in her blood group available. So that's manual digital exploration of the uterus and removal of retained products. Sadly, it's done in a female human, the same as it's done in a female cow. It's all, you put your hand inside, you remove it manually as gently as possible, because as we said, the uterus is very soft and friable. That is one of the reasons, say, when you're putting in a coil immediately after delivery, you are risking perforation much more than doing it after 6 weeks. Thrombin, okay, they're rare, but if you have patients who happen to be having HELP syndrome, so any of your operations with preeclampsia, or she bled a lot, then you're thinking of thrombin problems due to DIC. Or she suddenly collapsed, you think she may have amniotic fluid embolism or severe sepsis. These patients will also have such a rare thing as thrombin. To present the 4, we always have to know the 4 T's when you are being examined with a patient with PPH, which is always coming in the exam. You have to mention the 4 T's, okay? Then we go to coagulopathy. What do you treat? You try and treat the reason, whatever it is. You give enough blood, you give RBCs, you give frozen plasma, whatever necessary. The blood bank support is just irreplaceable. So now, administrators and administratively, many groups, we said about a quarter of women who die, maternal mortality worldwide is due to bleeding worldwide. So groups of obstetricians have tried to reduce this number by having more and more protocols, because it has been internationally recognized that protocols and training on them will work to improve the service, whichever service it is. So they instituted something called massive transfusion protocol, and that is when somebody is bleeding heavily and you expect to have a massive transfusion situation. Massive transfusion protocol is if you have bled, the lady is expected to have bled more than 1.5 liters. Now, do not forget, as obstetricians, we have always underestimated. So please try and overestimate. It will always help you. It will always, and do not forget that most of your patients are going to be anemic. So even the 1.5, I would think it more of a 1 than a 1.5. But for the purposes also, it's 1.5. So the component, the objectives of quantitative measurement of ongoing blood loss. Do you know what would really help is the old-fashioned المفرش اللي بحطوه الميدوايفز تحت العيانين. that gives you the best measurement of ongoing blood loss. In the modern states where there is lots of cloth, lots of gauze, lots of it's very hard to assess blood loss. So treatment of interventions. If you don't know what to do, just pack it until somebody comes who can do it. If you are lucky enough to have a balloon, and now they say that every unit should have balloons. I'm not sure at the moment where it is available and whatnot, but a balloon will do the same as packing basically, but easier to come out. And compression, at the end of the day, your seniors can always start doing compression sutures. All the rest, and in the end of the day, you want to save the woman's life, you're going to do a hysterectomy. Uterine tamponade balloon, you have to have which is this is what it looks like. When it's inside, that's what it's supposed to just pressurize the bleeding area. And this is, you're looking at atony. It's mainly in reference to atony. So if we're looking at a review of PPH management, we said we prevent it by active management of labor, which includes 3 components: oxytocin, controlled contraction, and uterine abdominal massage. That is active management of 3rd stage of labor. If you have more than 500 mil, you need bimanual massage and you need resuscitation, which includes oxygen, IV, preparing bloods. And before all that, ask for help. If you don't say ask for help, and also sagattu. Okay, I'm sorry to say that, but that's the way it is. We need to pass this also, other than the knowledge you get. Now, blood loss, we said they get platelets, they get, now, here the important bit is initiate massive transfusion protocol. It's a multidisciplinary team. It's consult anesthetists, surgicals, ICU, anybody, inshallah, the cleaner who is down, she will help you assess the bleeding and the amount of bleeding. So everybody is useful. There is groups of organizations, maternity care organized, basically Hawajat Lammu, and they said they are obstetric hemorrhage patient safety bundle. They created that. And there are different ways of expressing them, but the end result of it is they're trying to reduce the maternal mortality due to mashkurin. This is a good start for a new hospital or a hospital that wants to reassess its priorities and how they want to deal with it. So it's the same. Prevention, you have to be ready in a labor ward for recognizing bleeding. You have to be ready by having protocols. If you have a clear protocol, that's good. But there's no point having a protocol that sits in the cupboard. This protocol has to lead to improved response. If you have an improved response, and that is done by drills. If you have a protocol, you have to do a drill about it. And at the end of the day, hello? At the end of the day, you have to do reporting and reassessment and debriefs. The most important thing I can see in this page is hemorrhage drills. You have to have a protocol and do a hemorrhage drill. It's the same as MI crash cart. They advise to have a hemorrhage cart, the same as a crash cart. You know, in every big hospital, you'll find on every floor there's a crash cart. In a labor ward, there should be a hemorrhage cart, so that you immediately have access to drugs that are not expired, not out, not finished, not this, not that, not that. So every morning, this hemorrhage cart will be assessed to make sure everything is complete in it. And according to the protocol attached to it, you will have a response team who know how they are being called, who know how they will come, what is their job when they come. So one of them will know that they are supposed to do the IV lines, the other one will know that they have to put on the oxygen, and the team is not doctors. The team is headed by can be mostly headed by a doctor, although can be headed by others, but the team can have the nurses, the paramedics, whoever is available and on the protocol of that hospital and that unit. We try and do that as much as possible. Now, that drills with debriefs. So a drill, there's no point just doing a drill. You do a drill and then you do a debrief to find out what went wrong and why and how to avoid it the next time. And then you do another drill. Assessment of hemorrhage risk that is important to be done before antenatally. So if you are antenatally seeing a patient and you know that she bled in her last 2 pregnancies, 2 deliveries, and you know she's fat, you know she's anemic, you know there's any sort of risks, you have to put that very clearly on her file, on her handheld notes as well as her file. So wherever she delivers, people know to be ready the minute she walked in to manage her. And we need active management of labor like all other. Now, how you're going to assess the cumulative blood loss, these are different, quantitative, calibrated, all fancy. And at the end of the day, you need to assess how much bleeding happened. So we said every unit should have an emergency management plan. And here, of course, more fancy, they want a support program for patient families and staff. If your patient or your junior's patient just died with massive postpartum hemorrhage, you really have to sit down with this staff member. Hopefully, I'm sure my colleagues would do that, reassure you, to go through it with you and with your colleagues, because it's not only the person caring, it's the person next to him and their family and how they are affected by it. Some people may even leave Obs-Gynae due to such a disaster. So you have to be aware of that. So in summary, active management of labor. Number 2, intervene before something bad happens. So just if you start finding the patient starting to get symptomatic or the bleeding is not stopping, you need to start the management, which we said all the parts of it. Then we go to the 4 T's and look for the reason. And always, always try and make sure that your unit has a protocol and a safety bundle or a crash cart, or as good as you can get. As good as you can get within your circumstances. And I thank you very much. And that is the end of our, I hope I didn't take too long. Is anybody with me?
Thank you very much. Thank you.
You're most welcome. I hope it was that satisfied. Did anybody have questions? Anybody worried about something?
Thank you, Badreldin. Very useful presentation. وحقيقة الأهمية ما في المحاضرة دي موجودة في كل مكان، هتلاقينا في البراكتس وهتلاقينا في الامتحان الام سي كيوز وهتلاقينا في الميجا، كله ما في امتحان ما فيه الفورتيز.
بالضبط.
شكرا جزيلا دكتورة ماندي. لو عندنا أي أسئلة نقوم نسأل، لأنه المحاضرة دي مهمة جدا وهتلقاها متوفرة في الكورس ده كتير خالص خالص. Thank you very much.
You're welcome. Hello? If there's no questions, do you want me to get Professor?
تفضلوا يا جماعة، لو عندنا سؤال ممكن نسأل، ما في مشكلة. كله تمام؟
Okay.
Thank you very much دكتور ماندي. شكرا جزيلا. شرفتينا.
الله من ذوقك. اتصل بالبروفيسور ولا اخليه يستارت ولا عندك حاجه في النص؟
لا ما عندي حاجه والله، انا بس هنتظر بروفيسور بدردين.
ثواني ثواني. Here, take this one thing. It may be useful. Use this one. I'll take this. You take that.
Share screen. Share. Launch meeting. Launch meeting, correct?
She can hear you already. You're included in the meeting already.
مرحبا بك برو بدردين.
Hello.
ازيك يا بروف؟
مرحبا.
مرحبا بك برو بدردين، منور ومشرفنا اليوم ده. مرحبا بك.
الله يخليك، الله يسلمك فيك.
دايما
كيف
معاك
حالكم؟
يعني. الله يسلمك. كل اولادك بيسلموا عليك و شاكرين
انتوا are all together in one place? Are you all together in the same place?
Yeah. No. Everyone in yeah, no.
Separate places.
Yeah, separate place. Welcome.
Okay.
شكرا جزيلا. طيب يا شباب، نعرفكم ببروفيسور بدر الدين. في كثير منكم ما لقاه. بروفيسور بدر الدين هو كونسلتنت اوف سانجاينا، وهو من الناس المهتمين في مجال الفيتال ميديسين والالتراساوند والفيتال ميديسين الانترفنشن فيتال ميديسين. وطبعا في الدوحه من فتره طويله في قطر، من الناس اللي معروفين، والسي في بتاعته غنيه ما شاء الله عليه. هو دايركتور اوف فيتو ميديسين سنتر في الدوحه، بروفيسور اوبستريك انجاينا برضه في قطر في الدوحه في الجامعه، في مستشفى حمد في مستشفيات الدوحه. بروفيسور بدر الدين من المشهورين والناس المعروفين في الشرق الاوسط باسهاماته الكبيره بكل الحاجات اللي بيعملها. بروفيسور بدر الدين ناشر اكثر من 100 بيبر، عنده برضه عدد من الكتب. for example basic book of ultrasound and obstetrics and gynecology. برضه عنده book في diabetes pregnancy ultrasound. عدد كبير من المشاركات في المؤتمرات، إشراف من لعدد كبير من البيبرز والإسهامات الكبيرة اللي صعب نحصيها هنا في اللحظات دي. نحن بنتشرف كثير في الكورس ده يكون هو موجود معانا عالم من الأعلام. غير ده هو برو بدر الدين قريب لنا خالص، وهو من الداعمين للأوسو، وهو اللي جاب الأوسو من 2004. التجربة بدت برو بدر الدين، وحاليا معانا طبعا يا جماعه 133 دي ما كان ممكن تكون النمبر اوف كورسز بالدرجه دي لو ما عندنا ناس بيدعمونا وبنلجا لهم، وهم موجودين وحاضرين دائما في كل المواقف. مهما نقول ما حنقدر نشكره، وبنتشرف انه هو معانا موجود واكسسبل متى ما احتجنا له. انا بحسدكم على الفرصه الجميله والمحاضره الجميله اللي انتم حتستمتعوا بها في التراساوند الليبر. ويلكم يا بروفيسور، مرحبا بك، شرفتنا كثير.
شكرا جزيلا. Can you hear me? Can somebody say he is hearing me? Can you hear me clearly? Can you hear me?
Yeah, Prof. Yeah.
Okay, right.
And share
right.
your presentation.
I'm going to share the slide now.
Yeah, okay.
Can you see the slide now? Can all of you see the first slide?
Yeah.
Okay. Thank you so much for inviting me. I'm delighted to be here. Thank you, Dr. Mazin, for the very kind words. The team of also in Sudan did a fantastic job. All we did was the concept, but the chaps in Sudan, they did very well. I think I can safely say, and you're going to be surprised by this, I think Sudan is one of the best countries applying also course in terms of activity, in terms of number of graduates also. So that gives me a sense of pride. Today I'm going to speak about intrapartum surveillance. On Wednesday, I'm going to be speaking about ultrasound in also. So today is going to be about intrapartum fetal surveillance. I work in Doha, in this center called Fetal Care Center in Doha. And also I work at Cornell University, which is an American university based in Doha. And I've been here since 2002 in Doha. So today I'm going to speak about CTG, or intrapartum fetus surveillance. I hope you are all hearing me clearly and seeing the slide clearly. Mazin, are we all okay?
Okay, yeah, okay.
I'm going to ask you this question every now and then. Don't worry, because I just worry about speaking to myself, although I do it all the time. So about intrapartum fetus surveillance, what is the basic? The basic thing is two things. Either you're going to monitor the baby like this or like this. Like this, it means that you're using the Bernard stethoscope. Like this, it means you're using a CTG. Can I ask you, Mazin, how many of the candidates are actually using CTG? How many of the candidates using CTG? Of the have seen CTG machine? Is all of them, part of them, or none of them?
Part of them.
Part of them have seen the CTG machine, but not everybody. Correct? So you can either do continuous fetal monitoring by CTG, or you can use a Bernard, which is what we call intermittent auscultation. These are the two methods. Now, what is the idea of also? The idea of also is you face in the labor room to use standard statement. We refer to things like the National Institute of Child Health and Human Development. So we are all in the same page, because if you leave it, then everybody will have his own way of thinking. The idea of also is to make people think, all of them, in the same structured way. So there is a lot of good things about also, and there's some problems. So this the basic slide. And I put this slide, I hope you can see it clearly. This is an example of a good CTG. Example of a good CTG, where you can see here the CTG up. I'm going to talk about it later on. But what I want to say in this slide, that has been introduced long time ago, 1960s. Does it work? The answer is yes, no. What do I mean by this? I want you to remember this slide very well. The CTG is very good when it comes to sensitivity. The CTG, or the continuous monitoring, is very poor when it comes to specificity. In other words, the CTG is sensitive, but not specific. I want you to remember this. If you remember anything from my talk and you go home with this, I will be satisfied. What does that mean really? When I say sensitive, it means that if CTG tells you that the baby is normal, then the baby is normal. But if the CTG tells you that the baby is having problems, it does not always mean the baby is in trouble. I repeat again. The CTG, when the CTG is normal, like this CTG, then I'm 100% sure this baby is normal. But if CTG is very bad, and we'll come in details later on, the CTG is very bad, that does not always mean the baby is in bad situation. So it is high sensitivity and low specificity. And I will talk about it in more details. Now, we have two methods, as I said before. We can either do a Bernard, like we do in all the hospitals, anywhere in the world, even at home, with the midwife, or you can do like this one, continuous fetal monitoring, or CTG. This is what we mean by CTG. So I want you to notice here, there is something here very important. You can see there is two belts, 1 and 2. One belt is recording fetal heart, and the other belt is recording uterine contraction. So I want you to learn that the CTG, we want to study the relationship between the heartbeat and maternal contractions, because maternal contraction is the stress we apply to the fetus. And the fetus who is healthy will respond very well to stress, and the fetus who is not healthy will suffer. That is the principle. That is the bottom line. So, which one do you use? If you have a low-risk patient, you can use the BNARD, or what you call intermittent auscultation, or you can use CTG. But if you have high-risk pregnancy, then you have to use continuous fetal monitoring. What do you mean by high risk? This is very simple. You forgot about the slide. The risk can come from the mother, or from the fetus, or it can be something which arises in the labor room. So the risk can be from the mother, like here. She is diabetic, she is hypertensive, she has got problems with preeclampsia, or the problem can be in the fetus. The fetus is small, have a severe IUGR or fetal anemia. Or the baby can be normal, and the mother can be normal, but when she comes into labor, there's a problem. Like what? Like she's having oxytocin going on, or she has been induced, and then she's having a epidural anesthesia. So when I say to high risk, it's very simple. The risk came from the mother, or the fetus, or something arises because of the labor. This is what we mean by high risk. So in this situation, the CTG, or continuous fetal monitoring, is better. Now, in the low risk group, where they don't have any of what I've mentioned, you can use either continuous fetal monitoring, continuous electronic fetal monitoring, or intermittent auscultation. Now, people are fighting, do you use this or do you use this? And to sort out this, many years ago, some of colleagues suggested what we call admission CTG. What does that mean? They're suggesting to us that what you do is you do at the beginning for everybody CTG. And if it's normal, then you can go for electronic fetal monitoring, interrupted. But that did not take very well. Now here is the problem. Here is the problem. I hope you are all awake and you are all following me. I don't like this slide, but here what is saying, what are the evidence that electronic fetal monitoring is good? The answer is none. You can see here, there is no difference in Apgar score, no difference in NICU admission. There is slight improvement in the number of seizures for the neonates, but look here, high incidence of cesarean section and high operative vaginal delivery. Then the question is going to be raised, then why do we use it? And that is a very legitimate question, because we do not have anything better. So electronic fetal monitoring was many years ago, many years ago, and it failed to show any improvement in Apgar score and NICU admission. It slightly improved the number of seizures in the neonates at the price. What was the price? Increased cesarean section and increased operative vaginal delivery. This is a very important slide for you to remember. And also I will repeat myself again. Remember, CTG is sensitive, but not specific. CTG is sensitive, which means if CTG is normal, the fetus is normal. But if CTG is abnormal, the fetus may still be normal. This is very critical, very crucial to understand. What about the BNARD or the simple things? It works very well. The idea is to listen to heartbeat during contractions and in between contractions. So you have both hands. One hand on BNARD to get the fetal heart, and the other hand should be on the mother tummy to contractions. So you monitor the number of heartbeats during contractions and after the contractions. So basically, you're doing a CTG manually. It does work. It can be quite satisfactory if you do it properly. And I don't want to go in detail about how you do it, because that is not important, and you can learn about it when you go for the station. But the principle of the BNARD is that you put the BNARD on the fetal heart, and you put the other hand on the mother tummy, and you monitor the heartbeat during the contraction and immediately after the contractions, and at the same time you palpate the contraction to relate the heart rate to uterine contractions. Frequency of how would you look at the CTG? How frequent? It's very logical. CTG is normal and she's low risk, I see it less frequent. If the CTG is abnormal and she's high risk, I see it more often. So 30 minutes in the first stage of labor if it's normal, 15 minutes if it's slight worries, and it becomes less in the active phase, 15 minutes and 5 minutes. But the principle is the same. I'm always after the principle. The principle is you frequently review your CTG if you are worried. If you are called by during doctor to at CTG and you have CTG, maybe it's fine, go and have a cup of. But if I got doubts about CTG, I say, okay, I'm coming back. I come back after 5 minutes, after half an hour. So the frequency will depend on the findings. Now, please wake up if you are sleeping, because this has to be memorized, unfortunately. I don't like to bore people with memorizing, but you have to remember this. To interpret CTG or continuous electronic monitoring, we use a mnemonic called Dr. C. Brovado. This is nothing. It's just to help us to remember what to look for at the CTG. And I will take this one by one. So Dr. C. Brovado is just a mnemonic. So Dr. Mazin or Dr. Amuna or Dr. Aya, when they interpret the CTG, they can all think about this before they interpret. So we can all have a common ground. Like I told you at the beginning, I want the midwife to look at the CTG the same like the assistant midwife, the same like the nurse, the same like the registrar, the same like the consultant and the senior consultant. So what is the Dr. C. Brovado? Now, we take it one by one. One is doctor. Doctor for determine the risk. Before you look at CTG, is it high risk or low risk? What do I mean by this? A woman who is hypertensive and taking labetalol, the high risk woman. So I will look at CTG very carefully. A woman who is diabetic on insulin and she admitted to hospital with frequent hypoglycemic attack is different. A woman who has been fine, but she has been in labor for more than 14 hours. A baby who has been a small baby all through the pregnancy has been diagnosed with IUGR and have been seen at the fetal medicine unit at Soba for many, many days. So if the risk is high, then I'm more cautious. This is what we mean by DR, determined risk. So this is the first part of the mnemonic. So mnemonic number one, DR, determine the risk. What is number two? Number two is C, which is contractions. And here I want you to remember very well that when you look at CTG here, remember there is two belts, one for monitoring contractions and one for monitoring heartbeat. So I will look at the CTG and there will be two lines, one telling me about the heartbeat and the other one telling me about the uterine contractions. Because if the contractions are minimum, there's a problem, she's not in labor. If the contractions are maximum or over contracting, there's a problem. And we aim to have about 3 contractions per 10 minutes, less than 5 contractions every 10 minutes. That is the aim. If she's having more than 5 contractions per 10 minutes, it means that she's over contracting. And that may affect the baby. If the baby is coming, fine. But more than 5 contractions per 10 minutes, and 10 minutes is the thing we use. And then then you have to interfere. So I go back again. I said here the mnemonic called Dr. C. Brovado. So DR stands for determine the risk, and C stands for contractions. Now, so we said DR, determine risk, C, contraction, then we come to BRA. BRA, baseline rate or baseline rate. And here is we start the business. If you look at CTG here, Mazen, can we see the CTG clearly? Because I put it down here. Can you see it clearly?
Yeah.
Okay. Good. So the baseline, this is the baseline. Determine the baseline. So how do you do that? He wrote here. You want a 2 minutes interval to establish the baseline. If I look here, I put a ruler. So this is the baseline, this is the baseline, this is the baseline, this is the baseline. So the baseline, it has to be between 110, 160. So all of us, when we come to look at CTG, we know that we look at the baseline of the CTG. And the baseline of CTG is between 110 and 60. We are happy. There is no fast heart, tachycardia, and no slow heart, bradycardia. We are happy. That is the baseline. That is what it stands for, BRA. And this is the example. You can, as I said before, you put your ruler here and you can see this is the baseline, this is the baseline, baseline, baseline. And when I read it, it's about 140. I'm happy. Here, the same. So this is the normal baseline because it falls between 110 and 160. So a normal baseline. You can have baseline tachycardia and we can have bradycardia. Tachycardia means the heart is fast and it is more than 160. Bradycardia, it means the heart rate is low and it's less than 110. So we can have bradycardia, like here, this CTG. You can here see it is about here. So this is bradycardia. And bradycardia can be due to many reasons, but normally it is hypotension, hypothermia, hypoglycemia. It's always hypo. This can cause bradycardia, or if there is a prolonged labor, cord occlusion, fetal hypoxia, but it is unusual because there is a fetal bradycardia. It's not a normal baseline. It is abnormal baseline. We can also have, this is a picture, again, an example of fetal bradycardia. You look at here, I hope you can see it clearly. It is about 100. Here 100, here 100, here 100. So that is a baseline bradycardia. The heart is slow. We can have tachycardia, just the opposite. We can have a fetal heart rate more than 160 beats per minute. And here the reason can be hypertension, hyperthermia, hyperanxiety, dehydration, that sort of thing. But I'm not going to go into this, but what I want to say is there could be a baseline tachycardia, which means the heart rate is fast, more than 160, due to many reasons. And here's an example. If you look at the CTG here, and I'm sure they're going to show you in the station, you can see here, it is about 170, 180. So this is baseline tachycardia. I come back again to Dr. C.D. Brovado. So we said DR, determine the risk. C is the contraction. BRA, baseline, basal heart rate. And then we come to this one, which is V, variability. Now, if you are sleeping, please wake up for 2 minutes. And then I will tell you when to go back again to sleep. Because in the coming 2 minutes are the most important marker on the CTG, variability. This is the most important word. Like this. The more of this, the better. If you take 1 minute, the more of this, the better. If you see a straight line, this is bad news. Variability means fluctuation around the baseline. The more you have, the better. So you can have variability, be minimum, can be moderate, can be marked. All what you need to know that we want it to be more than 5 beats per minute. More than 5 beats per minute. If the variability is less than 5 beats per minute, we are in trouble. The most important sign of health in a CTG is a good variability. And I give this example in one of my cases, not also cases, but show you here is a good, this CTG is very good. Although there's deceleration, but I'm not worried because there's a good variability. So variability is very, very important. Here an example of absent variability. There is no variability because if I go back, here is variability is mean fluctuation, going up and down like this, like my cursor here. That is by fluctuation. Here, there is no fluctuation. It's a straight line. This is called loss of variability or absence of variability. This is not a good sign. This is a bad sign. There is no fluctuation above or below the baseline. This is lack of variability is a sign, one of the very bad signs. Now, moderate start to do this. It's very good. Here is more variability. It's very good, and so on. So, what is the cause of decreased variability? Again, is the maternal and fetal, like before. So it could be a baby who got problems like abnormalities, could be general anesthesia, could be alcohol, could be medications, or could be prematurity, or baby has good malformation or hypoxia. It doesn't matter, but can be so many reasons for decreased variability. If the variability is lost, this baby is not coping well with labor. If the variability is lost, the fetus is not coping well with labor, and you have to do something about it. Okay, we come again to our mnemonic. Doctor, DR for determined risk, C for contraction, BRA for baseline, and V for variability. Now, what about A? Acceleration. That is the sign of health. It means, what does it mean? It means you have the baseline here. This is the baseline, very nicely. And then when there's a contraction, the heart rate goes up and it comes back. This is a sign of health. Acceleration is when the baby jumps by 15 beats per minute above the baseline with uterine contraction. With uterine contractions. If you have acceleration on a CTG, that is a sign of health. Presence of acceleration more than 15 beats above the baseline is a sign of health. This is acceleration. And this here example of acceleration. You can see here, this is the CTG, and this is the uterine contraction. The upper line is the fetal heart. The lower line is the contractions. And you can see here, this is a contraction. There is acceleration here, away from the baseline. This baby is healthy. Here, there is contraction, heartbeat goes up, sign of health. Here, contractions, heartbeat goes up, sign of health. It means that the baby understands what is going on, and he has the ability to adapt by increasing the cardiac, the heart rate. And if you increase the heart rate, you improve the cardiac output and you improve circulation. A baby is responding. I come back again to our mnemonic. Dr. C, bravado. So DR, determined risk, C, contraction, BRA, baseline, V, variability, and A, acceleration. So what is D? D stands for deceleration. We do not want deceleration in a CTG. What does that mean? What does deceleration mean? Deceleration means that with the contraction, instead of going up, the heart rate goes down. Deceleration means it responds to uterine contraction. It responds to uterine contraction, the fetal heart rate goes down, like here, like here, like here. So it can be early, late, or variable. What does it mean? Very simple. Always remember contraction. When we say early, it means that it happened with the onset of the contraction. When we say late, it means that deceleration happened after the onset of the contraction. Here it happens, then later on happen deceleration. When we say variable, it means that it can vary in depth and in onset. I'm going to repeat this very slowly. I expect the CTG to show no deceleration at all. It should not be there. Deceleration means with the contraction, the heart rate goes down, not like acceleration goes up, it goes down, like here, like here, like here. It could be early with the onset of the contractions. It could be late after the contraction, and it could be variable. And if there is a deceleration, then means CTG is doubtful, So what about early deceleration? Early, as I told you, it means that the heart rate goes down with the uterine contractions. And this is less serious than the other ones. Give you an example. Look at here. There's a deceleration, there's a contraction here, and the heart rate goes down. So the peak of the contraction is here, and the peak, sorry, and the peak of deceleration is here. So they correspond to each other. If you draw a line, it will be the same. With the contraction, it comes down. That is early deceleration. What about variable? Variable, it means that it can happen at different duration, different onset, and different depths. And that's why it's called variable. It's not always early, it's not always late. And the decreased induction is always less than 15 beats per minute. Remember this 15, everything is 15. Extension is 15 above the baseline, deceleration is 15 beyond the baseline, and so on and so forth. So the number 15 is very important for CTG. And this is an example of variable deceleration. I look at this CTG here, there is a deceleration here, after the contraction, here with the contraction, here with the contraction, here's the contraction, there is deceleration, that's fine. Here with the contraction, there is contraction and it corresponds to deceleration. So this is called variable. It's not early, it's not late. It can happen both ways. So what about late deceleration? Late, it means that the fetal heart rate goes down at the end of the contraction, and that is very bad. It tells about problems with uteroplacental blood flow. So late deceleration is not a good sign. Let me show you an example. Here is the CTG, and you can see here there's a decrease in the fetal heart, and the contractions already gone. Contraction and came back to normal. It happened after the contraction. Look here, contractions happen here, and the deceleration happened after the contraction. That's called late deceleration, late. And that is again could be a sign of inability of the fetus to cope with labor. That is what we call uteroplacental insufficiency. This is what you call, this is called late deceleration. And this is an example of late deceleration. So as I said, as deceleration is concerned, is drop in the heart rate below the baseline by more than 50. Early, it can be late, it can be variable, and it can donate, it can tell me that the baby is in trouble and there is problem with the blood flow to the baby. Again, the late deceleration, and it's not only late, but it goes up for a long time before it comes back again. So its duration as well is involved. So if the duration of deceleration is long, again, it's the bad sign. What are the cause of decrease in the fetal heart rate? Suddenly, baby mother in labor, and suddenly she had abnormal heart rate. Most probably, this can be due to things like cord prolapse, or just simple things like van examination, touching the head, or could be just after ARM, or it could be that the mother is lying on her back for a long time and she's having hypotension. So there's so many causes for decreased heart rate, and that's why sometimes you can just correct it immediately. A woman who was doing very well, suddenly the heart rate comes down, and you just put her on the side, and then heart rate will improve. Or you look at her blood pressure, find her blood pressure low, you give her some fluids, heart rate improved. Or she's just needing some oxygen. You just put her an oxygen mask, and so it improved. So I come back to deceleration. I said to you, it could be early, it could be late, it could be variable. Now, I don't know why they put amni infusion, but let me tell you what is the story. Amni infusion or intra-amni infusion was done to try to delay intervention. What do I mean by this? Suppose you're in the labor room, sitting in the labor room, and you have a CTG where there's a many repeated decelerations. And I know the deceleration are because the head is compressing the umbilical cord. So I want to elevate the head a little bit of the umbilical cord so I can gain time until she delivers. That's the idea of the amni infusion. The idea of the amni infusion is to reduce intervention. Okay? And the technique is very simple. The woman is in labor, she is 4 or 5 centimeters in labor. You put in the vagina a tube, and you ask your assistant to put a normal saline, infuse normal saline very rapidly. This is one of my patients in Sunderland, long time ago. You can see here there is 1, 2, very severe deceleration. But we were not happy to do section because look at the variability, good variability. So we tried to avoid that by trying to apply amni infusion. And when we did amni infusion, that's what happened. You see, CTG improved dramatically. Let me repeat it again. So the idea of amni infusion is a temporary measure to release pressure on the cord, so the deceleration will disappear, assuming that everything else in the CTG is normal. That was done a long time ago, because at that time, we tried to avoid cesarean section at all costs. These days, nobody's doing it because nobody wants to avoid cesarean section. Actually, people wanted to find the cause for cesarean section. But this is a very effective methods. And we've done a few cases in Sunderland, and since I moved to Qatar, we haven't done it. But that is the idea. The idea of the amni infusion, intrapartum amni infusion, is to improve the CTG and to avoid intervention. I don't want you to be confused. What I just described is called intrapartum amni infusion, because we do antenatal amni infusion for rare cases. And we have done so many cases in academia last year and the year before for different reasons. I'm not going into this, but I want you to know there is 2 types of amni infusion, intrapartum or antepartum. What we talk about today is intrapartum amni infusion. Okay? So now there's a rare type of CTG called sinusoidal. And I'm really not interested very much, not because it's fancy, but because it's very rare. This is sinusoidal. Your registrar will call you to the labor room, or the SHO will call you with crying, please help me, I'm in trouble. You come and you see this CTG. Just a line, a straight line. No variability, no acceleration, no deceleration, nothing. It is called a smooth, wave-like, undulating fetal heart. And if this is persistent, this is imminent sign, the baby will die. Because this CTG represents severe hypoxia or represent fetal anemia, and it can kill the baby immediately. So sinusoidal rhythm, hopefully you will not see it very often, like this one. This is just before death. So if you have sinusoidal rhythm like this, get the baby out. Get the baby out. Okay? Now, I come back to just 1 minute.
Okay. طيب يا شباب، لو في أي سؤال نزل على الشات، ممكن ننزل السؤال بتاعنا على الشات. زي ما نبهتنا استاذه منى، المحاضره بتاع الدكتور اماني هتبدا الساعه 2 اللي هي الشولدر ديسوشن.
Now, I come back to the mnemonic again. I remind you, Dr. C.D. Brovado, doctor determined the risk, C is the contraction, BRA is the baseline rate, V is the critical variability, A is acceleration, and D is deceleration. What about O? O is the most important step. Overall assessment. What do you make out of situation? What do you think of CTG? Is it normal? Is it abnormal? And here where problems start. When we assess the CTG, we can say either it is category 1, category 2, or category 3. Again, this is just so that we can all speak the same language. But actually, it's not that important. It's just so we can all have a reference point. What does it mean? It means that we have category 1, where the CTG is absolutely normal. Category 2, we are doubtful. And category 3 is disaster. That's the bottom line. The bottom line is, if you write in assessment category 1, it means that I will carry on. I'm going to go have a cup of coffee and have a chat with my friend. I'll come back after 1 hour. No problems. Category 2, I look at CTG, things I like, things I don't like. I've said I will come back after 5 minutes to reassess. Critical word, reassess. Category 3, the baby needs to be taken out, taken action. So if I can summarize, category 1, one word, observe. Category 2, reassess. Category 3, intervene. This is my own making. So for category 1, observe. Category 2, reassess. Maybe reassess yourself. Maybe reassess with Dr. Mazin. Maybe reassess with Dr. Muna. Maybe ask for help. Call a friend. Reassess. But if category 3, get the baby out. Or intervention. And I will explain further. So, what about category 1? I like the CTG. It's one of my patients for a long time ago. It is the best CTG. Look at the baseline, normal baseline, no problems. Variability, excellent. Look at that. Very good here. Very good. Acceleration. With the contraction, the baby goes up. No deceleration. Going up, going up, going up. Fantastic. No deceleration. My overall assessment of the CTG, this is the hunky-dory, normal CTG. I'm going to go and have a cup of coffee, and I will see you later. Baseline is normal, good variability, no deceleration. There is acceleration present. Very happy man. Category 1. See you later. Carry on. Category 2, that's where we are confused. Because there is some good things and there is some bad things. Tachycardia, it's not good. Baseline is good, could be minimum. Deceleration present sometimes, absent sometimes. Is it recurrent? Is it moderate? Is the decelerations, are they retained quickly? They retain fast? There's deceleration, but there's good variability. Is the deceleration prolonged or quick recovery? And that's where we are different. That's where we are different. And I'll tell you a story when I finish. To tell you our bias, we're so biased as human beings. So, what about category 3? Category 3 is easy. I look at CTG, look at here, like the one I showed you. There is no baseline, normal, but there is no variability, no acceleration. This baby is in trouble. Get the baby out. There is a recurrent deceleration, recurrent variable deceleration, bradycardia, sensorineurism, whatever it is. So what do? Get the baby out. So to recap, category 1, a normal CTG. Category 2, doubtful CTG. Category 3, CTG. Category 1, observe. Category 2, reassess, reassess, reassess. Category 3, intervention. So overall assessment is when I look at the CTG, after I have applied Dr. CD Brovado, then I came to the last of this mnemonic, which is O, overall assessment. Overall assessment, if category 1, normal baby, normal acid-base balance for observation. Category 2, there is some unqualified, some abnormal sign, require prompt evaluation and effort to resolve the tracing. What do you mean by this? You could take 2 consultants and they will come and fight. Most probably, they will not disagree. But you need second opinion. You need to discuss with somebody. You need to reassess. Category number 3, predictive of very abnormal acid-base balance, and it is prompt intervention and consider immediate delivery. This is the bottom line, Shabab. This is the bottom line. So category 1, category 2, category 3, I told you before, I repeat myself again, this is just to help us to have the same wavelengths. So when Dr. Mazi ring me and say, Prof, I have a CTG, I suspect category 2, then I will drive and come immediately. If he said to me, CTG is category 1, I ask him on phone, he said category 1, I said, fine, carry on. And so on and so forth. So that it depends. That's why it helps you to be the same language. And as I said to you before, I don't like busy slides because it confused me. I'm an old man. So, but it's the same thing. Category 1, routine management, observe. Category 2, evaluate, surveillance, evaluate, surveillance, evaluate. Category 3, you have to deliver. The problem is here. And that's a big problem, and I'll tell you in a minute why it's a big problem. So what do we do? What do you do every day when you come to labor room and you have CTG, which is not nice? You take simple measurement. Oxygen, put the mother on her side. If she's overcontracting, take the centrifugal off, and so on and so forth. This is a simple measurement we do every day. And it's quite effective. If you just, sometimes you just put the mother on her side, CTG will improve. Sometimes you just put the oxygen mask and it will improve. Sometimes just oxytocin, it will improve. So these are what we call intrauterine resuscitation measures. And these are what you could do. So the CTG, I said to you before, is not ideal test. Ya Shabab, I just want to tell you, in medicine, when they tell you there is so many alternatives, then there is only one fact. And the fact is, we're not sure. Let me give you an example. If I tell Mazin, my brother have appendicitis, Mazin will tell me immediately that the management of appendicitis is appendicectomy. I can do it laparoscopically, I can do it conventionally, I can do it through the tongues or through the whatever. But the management of appendicitis is appendicectomy. There's one example. Let me give another example. Stress incontinence. A woman has stress incontinence. When I was young, your age, the treatment was anterior repair and posterior repair. When I was young, it was colbus suspension. When I was young, it was Marshall cranks. Then I went to UK and we changed a little bit and we were doing more colbus suspension. Then I worked for 3 years with the man, tried to convince me to become urogynecologist, but he failed. And he was doing a lot of sling operation. TTS, TTM, TTFs. There is so many operations for stress incontinence. And that tells you we're not sure about the management. So when people talk about CTG alternative, because we are not happy with the outcome. And that's why we talk about alternative to CTG. What are the alternative to CTG? These are the alternative. Sorry. I will come back to the other slide. Alternative is to do a fetal skull pH. Because if you take all CTGs who are abnormal and you do section, people will come crying and laughing at you. The most severe CTG, only half of the babies that are affected. The other half are laughing at you. So CTG is not enough. So that's why we will use skull pH. It's not very common in the state. That's why I also not talk about it. But that's what we do every day in Doha and in London and in UK. Skull pH. Other alternative is continuous fetal oxygen saturation. We put a scalp around the baby and we monitor the oxygen saturation. I have the machine, used this many times. It's not very effective. The new thing is the fetal ECG. Fetal ECG. We put an electrode over the baby's head and we monitor the ECG. These are like adult ECG. But the most important new development is this one, computerized CTG. Let me repeat what I said again. What I said, that the CTG alternative or support is the fetal skull pH. People are trying to monitor oxygen saturation continuously, what we call pulse oximetry. And other people are trying to use fetal scan or fetal ECG. But the new boy in the block, which is going to replace everything, is what we call computerized CTG. Computerized CTG. What does it mean? Computerized CTG mean we are going to rely on the computer to tell us if CTG is normal or abnormal. The computer was giving a feedback about normal CTG, like say 10 million normal CTG. They feed the computer this, how should normal CTG looks like. And then the computer will learn the lesson. And you put the baby and you put the electrode and you get the result here, and it will tell you if the CTG is normal or abnormal. Computerized CTG is coming in a big time. This is the future. So what is the summary? The summary is that CTG is widely used, whether you like it or you don't like it. Why I personally have problem with the CTG? Because there is a very famous study done many years ago. They invite people in the Royal College in London. Those who have been to London before, they know where the Royal College used to be. It used to be in a very nice park in central London. And in that place, they called senior consultant, not like me or you, no. They called the most senior consultant in UK at the time, and they invite them to the college, very nice place, with coffee and tea and beautiful secretaries, and they give them CTG to interpret. They give them CTG and ask them to put their opinion about the CTG. These senior consultants and professors, they put their CTG opinion, they say it's category 1, category 2, or category 3. And they collect the CTG from them and they ask them to go home. They invite the same people, the same group of people again after 6 months. What happens? They give very different evaluation. Now, when we quote this paper, people, oh, was all the study, it doesn't matter. Somebody repeated the study again, only a few years ago, and he got the same result, that the interpretation of CTG is not consistent. And that's why the idea came about having computerized CTG. This is the idea of computerized CTG. And I come with this slide. It came 1960 to improve neonatal outcome. It did not fulfill this. CTG, as you see here, have got a very good sensitivity, but it is very low specificity. What does that mean? It means if the CTG tell you that the category 1, then the baby is good, then that's very good, no problem. But if it tell you it's category 3, it does not predict poor outcome. I tried to work hard to hide the slide like this, just to make my point. So it is the lowest specificity and high sensitivity. So a category 3, where you all rush to theater, and I've done that hundreds of times in my life. Rush to theater, get the midwife, harass the midwife, shout at the midwife, and get it, and the baby came crying like mad. But if CTG is normal, then this baby is normal. So it is a good sensitivity and a very good possibility. And I'm going to, if you want to ask any question, please do. Mazen. Sorry, I didn't talk for a long time.
Thank you very much, Professor. for the nice and elegant and useful presentation regarding CTG. There are some questions on chat.
Go ahead.
Okay.
By the way, I wish I could see all of you. Well, I'm hopefully planning to make a series of lectures and to join you in a webinar. And hopefully when I come to Sudan, inshallah, I will see as many of you as possible.
Inshallah. The Amal Abdullah asked the solution using ammonium fusion.
Yes, you're talking about amylin infusion. Amylin infusion, we use normal saline. We use the normal saline, and it's quite effective, quite easy to use. All what you need is the normal saline, and you need the drip. That's all, nothing else. Put the patient legs up and put your drip, and the CTG will improve immediately. It becomes like this. I've done few cases, and I didn't publish it, but I just put it in review articles. So if you put my name, you'll find the review articles about amylin infusion, intrapartum, and antepartum. But as I said to you before, nobody's doing it anymore because very few people doing it because people are now not very keen to avoid cesarean section, or they try to avoid problems generally. But answer your question, Amal, directly, we use normal saline. Normal saline. Yes, warm, normal saline, room temperature.
Thank you very much, Professor. Any question? Any question?
Mazin, I'm going to see you again on Wednesday, the same time, for the lecture about the sound.
Inshallah.
The sound and also.
شكرا يا بروفيسور، شكرا لك وشكرا لدكتورة ماندي for the nice presentation regarding VBH. شكرا جزيلا.
Thank you all very much. We are working very hard. Please, Mazin, let me know if I can do anything to help you. We are here to help you. As much as you can help you, I will do my very best.
Yeah, okay.
And people who are in also, thank you very much. Good luck.
شكرا جزيلا بروفيسور، شكرا لك.
سلام، مع السلامة. باي باي.
باي باي. طيب يا شباب، شكرا جزيلا لبروفيسور بدر الدين المحاضرة الجميلة CTG، واكيد حنشتغلها في السيشن. نحن عندنا محاضرة ثانية مع دكتور أماني، لكن بعد نص ساعة بالضبط الساعة 2 حنبدأ، فدي فرصة ناخذ فيها بريك، نصلي ونشرب كوباية شاي ونجي راجعين. مبدئيا أنا بكون فاتح كل حاجة حتكون موجودة. اخذوا بريك شوية، صلوا واشربوا كوباية شاي وتعالوا لنا للشولدر ديسوشيا مع أمانة خليفة. شكرا جزيلا، شكرا لكم كلكم يعني.